Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health. It's my pleasure to welcome all of you to our ongoing webinar series that we conduct with institutes at the National Institutes of Health, entitled Moving from Hepatitis Discovery to Elimination, where we highlight NIH research helping to advance progress toward hepatitis elimination in the United States and around the world. Today, we're going to continue a segment of this webinar series convened by the National Institute on Minority Health and Health Disparities, Leaving No One Behind, where today we'll be exploring community partnerships aiming to reduce hepatitis disparities. Next slide, please. Just want to welcome everyone and encourage your participation. We have, as you'll soon see, we have a very robust program with some excellent panelists that will be providing their perspectives on the material presented. But we also strongly encourage your direct participation by submitting questions to the Q&A format that you see at the bottom of your Zoom page. These webinars are recorded and posted on our website at globalhep.org, along with the slide presentations. We also prepare a summary, a narrative summary, to highlight key themes coming from the individual presentations to help those that are looking at the webinars later can find material that they are seeking in particular. I also encourage you to stay up to date. As you'll see at the end of this episode, we have several webinars coming from this NIH series, one in July and one in August. I also want to thank my colleagues on the organizing committee at NIH that are listed here. As you can see, they represent a variety of the institutes and offices at NIH. I also want to thank my colleagues at CDC who also participate in this organizing committee. And CDC will be hosting a webinar later in the fall as part of this webinar series. Next slide, please. We're now going on our fourth year on this webinar series, and we have a really excellent set of materials that are available on our website, as I've already mentioned. And I strongly encourage you to go and take advantage of the recordings and advantage of the presentations, as they cover a wide range of topics from behavioral science, as we'll be hearing in part today, operational research, as well as basic science research. This is the fourth webinar in a series within NIMHD, all seeking to look at ways to reduce health disparities. One of the guiding principles of disease elimination that's relevant to hepatitis elimination is that the ultimate goal of disease elimination is the achievement of health equity, because no one is left behind when you truly eliminate a disease. And that's where we're in perfect harmony with the mission, of this institute, as a way of eliminating those disparities so that we can achieve hepatitis elimination. Next slide, please. So this is our webinar, just to begin to transition to what we'll be discussing today. As you'll see on the screen, I want to thank my colleague Lindsay Hebert, who's functions as the producer of these programs, and she'll be joining Dr. Rena Das to moderate the panel discussion that will be occurring later on in the program. But now I'll turn it over to Rena to get us introduce the agenda and to begin to moderate the session. Rena?
Thank you, John. And Hi, everybody. My name is Dr. Reena Das, and I am the Division Director for the Division of Integrative Biological and Behavioral Sciences at the National Institute on Minority Health and Health Disparities. And I welcome you all for this webinar series on hepatitis elimination. We have a great session planned for today. And as you can see on the slide that we have a session planned with a unique set of team. We have two teams of speakers. These are researchers and community partners who are going to share how best to develop collaborations that focus on hepatitis B and hepatitis C elimination to produce really quality community service and research that have been shown to be effective in reducing the burden of hepatitis in various communities. So we have panelists and we have team speakers. So excited to get started. And to get started, we had initially planned to have welcome remarks from our NIMHD director, Dr. Eliseo Perez-Table, but he couldn't make it. So I will be providing a few opening remarks for today's session, and then we'll get started with the speakers. Next slide. Okay. So for today's session, as we said, the title of today's topic is Leaving No One Behind, Community Partnerships in Reducing Hepatitis Disparities. Can you go back one more slide, please? I just wanted to have acknowledged the partnerships that we have with the Coalition for Global Hepatitis Elimination and the Task Force for Global Health. It has been a great partnership, and this is our fourth effort in bringing topics that are relevant to our institute to all of you. And this session is going to really be unique, that is going to highlight research collaborations with community-based programs to reduce hepatitis disparities. Next slide. So I just wanted to give you a brief overview of what NIMHD's mission is. Mission is to really support minority health and health disparities research. And we define health disparities as having an adverse health outcome that can be attributed to social disadvantages that populations face, which could be due to result of discrimination, oppression, being underserved in healthcare settings. And the populations that are interest to us are populations in the United States that experience health disparities, which is poor health outcome compared to the other populations. So when we say populations with health disparities, what we mean are the racial ethnic minority populations that are categorized by the OMB directive. You may have seen the new OMB Directive 15 that came out. So these racial ethnic minority populations include American Indian or Alaska Native, Asians, Native Hawaiian or Pacific Islanders, Blacks or African American, or Hispanic or Latinos. And this year, OMB included Middle Eastern or North African as one of the minority populations. In addition to those OMB categories, NIMHD is also interested in less privileged populations from lower socioeconomic status, rural population, sexual gender minorities, and populations with disabilities. So next slide, please. So you may have seen this research framework before, and NIMHD has been really promoting to use this framework that shows that health disparities is complex and is multifaceted. So focusing on one factor or one level may not be effective in reducing disparities. If you see on the left-hand side, we have a list of domains that influence health. And on the top panel, you will see different levels of influence from individual level to system or society level. And most of the research focuses in one of those boxes, if you see maybe at the individual level, looking at either biology or behavior. And those, just looking at those alone may not be sufficient in reducing disparities. So we have to be mindful and look at multiple factors at the structural level, at the system level. Multi-level research is what we like to encourage people to consider to reduce health disparities. Next slide, please. So just wanted to say why NIMHD is interested in this topic. So when we look at the data at the national level, if you see, this is a graph that depicts hepatitis prevalence disparities by demographics as reported by CDC. So at the national level, there is a huge disparity between different racial and ethnic minority populations. The top graph here shows that chronic hepatitis B, if you look at the graph, it's highest among Asian American, Native Hawaiian, and Pacific Islander, AA and HPI population compared to the other population. And this is about almost 11 times higher rate compared to whites. When you, and the acute hepatitis B has been reported to increase in Black population as well recently. And these infections could be due to a variety of causes, and it has been seen to be prevalent in foreign-born individuals, but the data is not very clear. The collection of data is not routinely done in terms of the country of origin in research. So that's something and that could be improved. The lower graph here shows the rates of hepatitis C in different populations. And you can see the chronic and also the acute HCV rates are highest among American Indian and Alaska Native populations. So there is a concern that these rates are so high in these populations compared to the other general populations. When you look at the mortality rates, they also show a similar trend. Data shows that for HPV, hepatitis B related deaths, A and HPI have 8.5 times higher rate compared to whites. And for hepatitis C death, it's 3 times higher in AIAN compared to whites. So that's the reason NIMHD is interested to understand what are some of the causes that are driving these disparities and why do they exist and how can we best address them. We know that hepatitis is preventable. We have vaccines available for Hep B. We have treatments available for hepatitis C. However, the uptake of these are very limited, and they are even more limited in underserved populations. For hepatitis B vaccine coverage, we see only about 23% uptake in various populations. And when you look at the HCV curable treatment data, only 40% of individuals infected with HCV are even aware of their infection. And 1/3 of the insured patients undergo treatment, and they are much lower in uninsured populations. So both of these hepatitis infections rates are something that NIMHD is trying to figure out how to address them, how to understand the causes of them, and how to eliminate them. And when you look at liver diseases and liver cancer burdens, they are also higher in racial ethnic minorities. Next slide, please. So this is a slide that shows that liver cancer mortality. This is a graph that shows the mortality rates. The incidence rates are also very similar to race ethnicity. I just wanted to point out that the top level, if you look at the green top line, that is for American Indian and Alaska Native, and that's the highest burden. And that could be due to a lot of different reasons, and we need to have a good understanding. Also wanted to point out that Latinos have also the highest liver cancer incidence, and among Mexican origin populations, it matters where you live. If you live in the southern part of Texas, that's where the rates are much higher. So we at NIMHD have been very interested in trying to promote research in these areas. Next slide, please. So this is a funding opportunity that NIMHD, along with National Cancer Institute, promoted in 2017 to understand the mechanisms of disparities in chronic liver disease and cancer. And this was a great success partnership with NCI, and this was reissued in 2020. We funded a few grants in this topic, and we would really like to see more people submit their applications to NIH to really understand what are some of the underlying mechanisms that are driving disparities. And we wanted to promote people to look at the social determinants of health because, as I said, the research is mainly focused on understanding maybe changes in the gene or behavior, changing screening patterns, but really combining different structural factors and social determinants of health is something we are interested in that may help us understand what drives the disparities in liver disease and liver cancer. So next slide, please. So we have some understanding of what are some of the causes. So we created this new funding opportunity announcement that came out just this year. And these are to promote research on interventions to reduce health disparities. And this is the title, Interventions to Address Disparities in Liver Disease and Liver Cancer, PAR 24-207. So this funding announcement NIMHD created in partnership with other institutes to really encourage researchers to submit applications on multi-level, multi-domain, community-engaged interventions to conduct in populations that experience health disparities in liver disease and in liver cancer. And some of the priorities are, as I mentioned, community-engaged intervention studies is of great interest to us because we know those have been very successful in some of our other programs at NIMHD. Multi-level interventions to improve HPV and HCV screening and linkage to prevention and care from multiple marginalized populations are of great interest to us. Then intervention strategies promoting HPV vaccination, promoting HCV treatment, uptake, adherence, and completion to reduce disparities. All of these are of great interest to us. So please take a look at that. And if you're interested, do keep in touch with us. Next slide, please. So this is my last slide. So basically what this ties in with the theme of today's webinar, NIMHD encourages community partnership in research. We have an extramural division on community and population sciences. So we understand that if you want to make a difference in populations that experience health disparities, you have to partner with the communities where people live so that you can get the lived experience to address the unique needs of various communities in the US and address the health disparities. So equitable partnership is essential to the success of Hep B and Hep C reduction strategies. And so today's session is really timely because it focuses on highlighting examples of effective collaborations with community partners. What are some of the lessons learned and how these partnerships have been able to impact some of the Hep C and Hep B issues in the communities. So with that, I like to start with our first speaker. Next slide, please. So with that, I'd like to get started with our speaker panel. The first team that we have is from University of California, San Francisco, and the community partners are from End Hep C SF and SF Hep B Free. So Dr. Tung Nguyen is a professor of medicine at University of California, where he provides primary care to diverse patient population. His research focuses on achieving health equity using community-based participatory research and also patient-centered outcome research. He has been involved in various interventions for culturally and linguistically tailored interventions to address cancer, tobacco control, hepatitis B and C screening, among other topics. And he will be joined by two of the community partners, Mr. Jordan Ackley, who serves as the strategic director of End Hep C SF, a multi-sector initiative working towards hepatitis C elimination in San Francisco, California, and Mr. Richard So, who's the executive director of SF Hep B Free Bay Area. He's passionate about fighting Hep B and liver cancer in Asian Pacific Islander communities, and he has worked in healthcare for over a decade with a focus in public health. So we're really delighted to have this team. So I'll turn it over to Dr. Tung Nguyen to get started with this first partnership.
Thank you, Dr. Das, and thank you, the organizer, for having us come and talk about our experience in San Francisco, California, in the US. Next slide, please. So just a bit of background. San Francisco is a large city in California with a very diverse population, approximately 38% non-Hispanic white, 35% Asian Americans, 15% Hispanic Latinx, and 5% Black Americans. And here's a graph showing the viral hepatitis rate in San Francisco in the red compared to the other counties in the state and the state of California in the blue. And since 2000, our prevalence rates have been higher than in the state, with a spike between 2004 to 2008. And we believe that this sharp spike may be a combination of demographics along with community-based activities like SF Hep B Free. You'll hear more about this work from Richard, but I wanted to show this paper from 2011 that shows some of the work that was done that may have led to the increase in screening and thus the diagnoses. Next slide, please. For hepatitis C, the prevalence in San Francisco has also been higher than in California. And again, this may be due to some combination of demographics and community-wide activities, including NHEP CSF, which started in 2016. This program was presented in a meeting last year, but Jordan will be telling you about one particular project. This photo was taken in front of City Hall for a press conference for both the Hep B and C efforts, and it includes members of the Board of Supervisors, the Director of the Department of Public Health, media personalities, community members, and researchers. And just wanted to show you that these efforts are a part of the city and county's various stakeholders. Next slide, please. Since this is about community engaged research, I just wanted to level set a little bit. This is sort of my rubric of what I think of when I think about community engaged research. There are basically three levels. Community engaged research, which is usually academic led and community engaged. Community-based participatory research, which is academic and community co-led usually. And then community-led research, which is fairly new and which is led by the community and with the participation of the academics. Next slide, please. So I want to show you an example of community engaged research in hepatitis B control for Asian Americans. This is a few years back. It was a program grant funded by the NCI and NIH. It was for our team to conduct community engaged research in hepatitis B control for Asian Americans. We had 3 projects, each tailored to one Asian national origin. One was a quasi-experimental project to test immediate intervention for Vietnamese Americans. The second was an individual randomized controlled trial to test a lay health worker intervention for Hmong Americans. And the third was a group randomized controlled trial to test a church-based educational intervention among Korean Americans. The level of community engagement varied. For the media intervention, community members were on an advisory board and participated in focus groups. For the lay health worker intervention, they also led a community organization that recruited lay health workers. And of course, the lay health workers were community members. And for the church intervention, Korean church leaders were involved in development and implementation, but the academic team did the design, development, implementation, and measurement. Next slide, please. Here are the results. I'm going to go quite quickly to them. The quasi-experimental study for the media campaign for Vietnamese Americans showed that the campaign was actually not more effective, possibly because of activities in the control community. However, exposure to the media elements was associated with receipt of Hep B screening. for the randomized control trial of like health worker outreach among adults, the intervention did show a significant 3 to 4-fold increase in receipt of hepatitis B screening. And similarly, for the church-based intervention, the intervention led to a 5-fold increase in Hep B screening. So this, to me, shows that community-engaged research can have medium internal validity, as in the quasi-experimental study, and high internal validity, as in the 2 randomized control trials. However, these studies are not highly generalizable outside of the population that they were designed for, and even perhaps the geographic location where they were conducted. And more distressingly, both of the highly effective internally valid interventions have neither been replicated nor sustained. Next slide, please. Tell you about one other project. This is a project that was funded by the Patient-Centered Outcomes Research Institute. A group randomized a study of the physicians to study the effect of a multilingual mobile application on Hep B and C screening in the primary care setting. Can you hit the next click, please? Keep going, please. Okay. So the providers in both arms receive a panel notification of those who have not been tested. And the intervention group of patients actually got an iPad application. Can you hit the next click, please? Basically, they all used the iPad application and brought a printout to their doctor. Next slide, please. And this is where the community and patient engagement occurred. They had a patient and community advisory board. They were all engaged in the development of the intervention, including the app, along with other community members. They helped us to troubleshoot issues around recruitment. We also engaged clinicians and clinic staff, which is another set of community members in the design of the project. Next slide, please. Just as a table 1 demographics, simply to show here mostly that the patients that were in this project was actually fairly reflective of the Asian American population as a whole. Next slide, please. And this is the outcome. We discuss, we measure several things, but the main thing to look at here is the testing done. This is electronic health record verified testing. And the intervention group had 7-fold odds of having actually the screening done for hepatitis B. And for those who did not have hepatitis C screening, 10-fold of getting hepatitis C screening. So a fairly effective intervention for this particular project. Just stay there for a second. So the bad news, though, that is when the research project was over, we were not able to sustain the intervention either within our own health system, and uptake outside was low. Next slide, please. I think we can all agree that community-engaged research is better than traditional research in terms of identifying and addressing community needs using methods that are appropriate to communities. But there are other factors that go into choosing a particular research method, and there are trade-offs. This is a rubric of how we can think about the effectiveness of intervention research. Starting with internal validity is the finding reliable based on the study design and implementation. Generalizability is the finding related to settings outside of the project. And sustainability, how the intervention will be continued when the project ends. So for example, in drug studies, internal validity has to be high. Generalizability is medium due to inclusion and exclusion criteria and research participation bias. And sustainability is high because our healthcare system pays if the drug is effective. For community-engaged research, since academic researchers design them, they tend to have medium to high internal validity and medium generalizability. But since we don't have payment system that actually pays for behavioral interventions often, many of these are very hard to sustain, and I think I've shown that in the examples. CBPR has a better chance of sustainability because communities, public health, and other systems could be involved. However, because it's local community-specific nature, the generalizability can be limited. And community-led research, which is a brand new field, I think these issues are open. Next slide. Yeah, I'm really sorry. These are not the new slides that I sent, but we'll go with it. Fundamentally, the main barrier to sustainability of community-engaged research is structural. who will pay for effective interventions. A true academic community partnership need to go beyond individual research projects. And due to all that we've learned, including some of the things I've shown, our cancer center created a San Francisco Cancer Initiative with the goal of reducing cancer disparities across San Francisco. This collaboration between our healthcare system, community groups, government, and academia. And this accounts for, addresses 5 cancers, which account for nearly half of that in San Francisco. And one of them is, of course, liver cancer. Next. And so our liver cancer task force within the SF Can initiative, our goal is to reduce liver cancer morbidity and mortality in San Francisco through Hep C elimination, Hep B elimination, increase liver cancer screening and access to liver cancer treatment. And actually related to what Dr. Das was talking about, we also have a few projects looking at the adequacy of screening and treatment for hepatitis B and hepatitis C within our healthcare system. With regard to the first 2 bullet points there, our partners in this work is NHCSF and SFFB Free. Click, please. And you can end. I'm going to just turn it over to Jordan now to talk about NHCSF. Thanks.
Thanks very much, Dr. Nguyen. So like has been said, NHCSF is a community-based initiative. We work closely with our local health department, also with clinicians, frontline workers, policy advocates, community members, and researchers. Next slide, please. So to begin, I want to share a bit about NHCSF's core values. The values that guide our work include that everyone deserves access to resources for HCV prevention, care, and curative treatment. And I really want to flag here, the focus of my few minutes here will be on that we really feel like it's imperative to draw on the wisdom of people who are impacted by HCV, including people who use drugs, people with experiences of houselessness, and other communities that are impacted by HCV-related disparities. We think that this community involvement is really critical to address disparities in our city. Next slide, please. So the program I'm going to focus on is our Community Navigator program. And this builds on our belief that our work is most effective when people with lived and living experience are meaningfully involved in this work. Our Navigator program is an example of this commitment. So the program itself trains people supports and trains people with lived experience of HCV and or substance use to advocate for other community members. The way that we do this work is we fund several community-based organizations to host the program. The staff at those organizations recruit and support navigators who are embedded at those agencies. And then our initiative actually provides foundational training as well as ongoing community building events for those navigators. We've been doing this since 2018, and we've trained more than 120 people. We really feel like peer support has been an effective strategy to engage people who are most impacted by hepatitis C in San Francisco in prevention, care, and particularly to reach communities that may have experiences of mistrust and or face barriers to accessing care either geographically based on systems or based on sort of disproportionate impacts of morbidity and mortality related to HCV. So through this program, we continue to build our understanding of community priorities, continues to shape the work that we do and the areas in which we focus. And I will note that in the past years, we've actually been expanding our partnerships to conduct needs assessments in conjunction with the health department, and navigators from our program have gone on to have employment through different sort of community-based participatory research projects and as staff and community-based organizations. Next slide, please. Just a snapshot of our accomplishments and sort of how the program works. One of our cohorts, which runs in a 6-month cycle, had featured 17 community navigators from 4 community-based organizations. In total, they provide 750 hours of service, more than 4,000 interactions with individuals in the community. The navigators themselves conducted 99 HCV antibody tests, distributed over 500 doses of Narcan, and reversed 16 overdoses. And many more folks in community were directed and supported to link with other testers at the community-based organizations that we partner with. Next slide, please. So in summary, NHCSF has found that partnering with people with lived and living experience enhances our work and importantly recognizes the expertise of people who are most impacted by hepatitis C. Next slide, please. So here's my email address. I wanted to keep my remarks brief, but we continue to learn a great deal through our Navigator program, and I'd be happy to share detail about our experience and answer any questions either via the chat or by email. And thanks to our partners for this opportunity to speak today.
Thank you, Jordan. And I'm going to ask Richard So to present on Hep B, please.
Thank you. I'll share screen now. So thank you first, Jordan, for your presentation. We actually work often together to amplify our work and hope to do more of that. So my name is Richard So. I'm the executive director of SF Hep B Free. And we are a small community-based grassroots nonprofit that really works on hepatitis B awareness and free screening in the San Francisco Bay Area. Just so a little bit of background, we actually began all the way back in 2007 for becoming the first of its kind, really grassroots-based collaboration between quite a few sectors of society. Really focused on educating, screening, and linkage to care, bringing together a major player in the DPH at San Francisco, health systems. Almost every health system, hospital, and general clinic network was on board in our big overall meetings. And then community players. At the time, Asian Week was a large player. And so we had kind of our ear to the ground for folks in Chinatown and a lot of the Asian Pacific Islander organizations. You can see a little bit on your right. It was in collaboration with then Mayor Gavin Newsom and Assembly Member Fiona Ma. There were several bus ads. You can see the ad that was put on like bus terminals and shirts, and we even had a major ABC anchor, Alan Wang, who talked about it. So a major push then. Since then, it has continued fluctuating depending really on funding, which brings me into the next slide, which is really the challenges and barriers for many of the researchers who are on this call. As you can imagine, for hepatitis B, the first initial challenge is the lack of awareness for both the public and some providers. Providers have gotten much more informed. We'd like to think that some of our work, but also just the work that many researchers and advocates have done. But for those of you who don't know, currently it's still mostly up to providers, individual providers, to really know who to screen. Now, fortunately, the CDC, as many of you know, came out and said everyone should be tested once. And here in California, we, as well with our other advocates, promoted a law that requires physicians to offer a free hepatitis B and hepatitis C test in the non-emergent setting. But also, as many of you may know, in order to pass that law, we had to write in that there was not going to be any punitive damages if physicians did not do that. So unfortunately, it's really still up to patients to request. Now, fortunately, anecdotally, as we've been out in the community, we see a little more testing. Folks actually have said, oh, I actually got Hep B tested. It got added to my test, which is great. On the other hand, some folks have said, oh, no, I still don't know about this, and I just saw my doctor. So we'll see. We, particularly for Hep B, have a lack of quality data in the city of San Francisco and across the counties. As many of you know, the difference between acute and chronic is not well kept. And every time for research and increased funding, people ask, well, what's the burden? What's the need? And unfortunately, public health institutions often don't have the resources to have that in a confident way. And so that's a major issue for us in the Hep B field here. We've quite frankly been told, so used to be during certain years, we had enough that we would fund a position that could really clean this data and have a more confident view of it, but that hasn't always been the case. Go into kind of the challenges that many residents face. That's linguistic and cultural. Many are Asian immigrants who don't feel confident interacting with a provider, especially at the specialist level, who may not speak their home language. And then the stigma and misinformation that is common as an STD, even though many of you know the vertical transmission is the main way that Hep B is passed, you still have this deep stigma, especially across immigrants that come from countries where the disease is very stigmatized, preventing people from getting married or job opportunities. Moving on, we find it quite difficult to reach large numbers of our target population in efficient manners. And we know that this is just a issue that everyone deals with when you have a target population that's specific. So we end up going to lots of nonprofits that serve these communities to reach those audiences. We do reach folks through Chinese radio and TV, but we don't know how much behavior change that's going to actual cause, nor are we able to track that. And so that brings us to the next one. Creating behavior change is difficult. We've had some talks of mistrust in the healthcare system, especially in the Pacific Islander population, who often feel stubbed and left behind by all sorts of services. But we have faced that significantly, and we're trying to address that and build trust in the PI work that we do. There's a lack of urgency, unlike other diseases that are quite, I guess, I hate to say it like this, like showy or more immediately causing mortality. As many of you know, hepatitis B usually doesn't cause the liver cancer until later in life. And even then, there's no direct tie to Hep B that seems visible that people know about. So there is very much this sense of, I feel fine right now. Why should I do anything? And then finally, there's the lack of funding. This applies, we know, to so many issues, but particularly Hep B, because it's a mostly Asian American, African immigrant issue. There's just very, very little funding out there. For those of you who are in research or know about Hep B treatment drugs, the pipeline is getting smaller and smaller. The number of industry working on it is smaller and smaller, therefore making the funding from those industries smaller and smaller. And it makes it really hard for us to do more work. For those of you who don't know, all this work that we do, we have a staff of 2 full-time people with SFFB3. So on the other hand, I want to talk about best practices. It's really about understanding the audience in terms of who, where, and how. I think these are extremely critical and things that seem obvious, but really need to be done to be effective, especially when you have a small team. Like, who is your audience? And that's specific. If it is a Cantonese audience versus Mandarin audience, if it is a Pacific Islander audience, do your education folks look and sound like those people? Where are they meeting? This is a common thing. People go, let's just make put out a table and educate folks. But if you're not meeting them, in their community zones, that's just not going to work. And we have some examples right here. The top picture is at a place called Self-Help for the Elderly that gathers a lot of old Asian elders for food and just social activity. The top right is in Chinatown during the Lunar New Year. The bottom left is at KTSF, the major Chinese TV station. And then the bottom right is employees at a Chinese dim sum restaurant. And so you can really see that we try to meet folks where they're at, and that's critical. And you also want to do that by leveraging community stakeholders, which can make a huge difference with just a little bit of communication. What health systems work with this population? What elected officials have sway with this population and give you their their blessings? What nonprofits are working with them, and what ethnic. Just wanted to show all sorts of the other work that we do. From the top left is a newspaper clipping in collaboration. You can see with 2 other partners, the Peninsula Healthcare District and the Asian Liver Center. Middle top is our work speaking to employees at a market in the city of Millbrae. Top right is at another dim sum restaurant. Middle is again a big city hall proclamation. And bottom right was our first foray into targeted digital PSA marketing, which, as many of you know, is like a major way people are getting information as opposed to mainstream media. So we tested it out, but that again is a kind of costly investment. Work in numbers. I'm not going to go through all of this, but you can see kind of what we attempt to do. We really try to get as many events done, whether that's talking to 10 people or 100. Our screening numbers are not that high because, again, we're not tied to a medical clinic. but we're proud of the numbers we do get. We try to do physician education. Direct education is when we feel like we've had a real educated conversation with a person one-to-one. So we're really proud of those numbers. These are literally like, I talked to you for 3 minutes to tell you about it, and they're listening. And then our indirect education accounts for radio, what we estimate for things like radio, TV, and newsprint. And so we're really proud this year. In the first 5 months, you can look at our numbers, and they are larger than many of our other years' full years. So we continue to try to do great and expansive work. Just really quickly, these are some other couple examples. I want to particularly note the 2 middle pictures. The AB 789 was the law that it requires primary care providers to offer that Hep B and C. That was in 2023. And then we do a lot of proclamations, as well as educate physicians. That's your bottom left picture. And then look for grants. And so again, to address sustainability, it's really the need for grants and fundraising. So if there's a better way for all you researchers out there, how we can better collaborate with you all to find those resources and work closer with all of you researchers. For example, SF Hep B Free, because we're such a small shop, not tied to an academic medical center, we would love to work better to improve data with any researchers out there. I really just don't have the bandwidth to really look at that up. So by all means, please contact me. I think that's it here. I thought I had a slide that said questions, but I think that's it. I know I said a lot in a small amount of time, so thank you for your time.
Thank you. Thank you, Tung. Thank you, Jordan. Thank you, Richard. I think that was a great collaboration and presentation of how community members and how academic institutions are working to eliminate health disparities in hepatitis. So in the interest of time, we will save the questions that we have received till the end when we have the panel discussion. So let's get the slides back on for our next presentation. Our next group of partners are from Purdue University and Indiana University. So this is a partnership between the academic institution from Purdue and the community partner is from Indiana University Health Positive Link. So to start us off is Dr. Monica Casting. She's an assistant professor of public health at Purdue University and an associate member of the Cancer Prevention and Control Program at the Comprehensive Cancer Center. Her research has focused on examining predictors of hepatitis C virus, screening human HPV vaccine uptake, and various determinants for preventive health decision-making. And she'll be joined by Emily Branger. She's the manager of the prevention services at Indiana University Health Bloomington Positive Link. And she has worked in the area of HIV for 25 years. Currently, they provide HIV and HCV outreach and testing, as well as assist people in accessing PrEP and HCV treatment. So please join me in welcoming Dr. Casting and followed by Emily Branger. Take it away.
Hi, thanks for having us. As Dr. Das said, I'm Monica Casting from Purdue, and I'll be co-presenting with Emily Brenniger from IU Health Positive Link. Next slide, please. I don't want to repeat the background information from the webinar introduction, but what I do want to highlight is something that Richard also mentioned in his talk, which is that hepatitis C virus screening is universally recommended for all adults ages 18 to 79 years old. Next slide, please. And another thing is that this screening process actually includes 2 steps. So the first step is a Hep C antibody test. And if that's negative, the person is considered not to have hepatitis C and no follow-up testing is needed. If that is positive, they need a follow-up Hep C RNA test. And then if that's negative, it means they had Hep C at some point, but it has cleared on its own and they don't need treatment. But then if that follow-up test is positive, that means they have a current active infection and they need to be linked to care for treatment. Next slide. As stated in the introduction, there are many barriers to care and disparities for Hep C, including many NIMHD populations of interest. And a few additional things I want to further highlight is that some of the challenges to care include lack of awareness of infection, with half of people being unaware that they're infected. A lack of linkage to care, so only 43% of people who have tested positive have access to outpatient care. And then the price and access of treatment. So of all the people diagnosed, only about 9% of them achieve cure. Next slide. To bring it a little closer to home and orient all of you to what's happening in Indiana, which is circled there on the map in red, there's a publication of surveillance data from 2015 that reported that Indiana was one of 7 states that had acute Hep C infection rates that were at least twice the national average. So now since then, there's been a large investment and huge efforts towards Hep C elimination across the state. And I'll go through those quickly and highlight some of the efforts. So I think we can probably click 2 slides. Yeah. This is from a publication I worked on, led by my colleague, Dr. Lauren Nephew. We looked at changes in treatment rates over time, along with relevant policy changes. And on the left of the graph, starting in 2011, is when new direct-acting antiviral treatments started to be FDA approved. And you can see that treatment rates with just the approval and availability of treatments didn't improve too drastically. But on the contrary, the largest section there in the middle of the graph is when Indiana expanded Medicaid. And the very last section is when Medicaid treatment restrictions were removed for Hep C. So as you can see, we didn't see large improvement in treatment rates just when new drugs were simply available, but when we started to see large improvement was once those treatments were widely available and affordable for people. Next slide. Some community-based initiatives also happening in Indiana that I want to highlight include Connect to Cure, which is a linkage to care program for people in Indiana living with Hep C. In addition, they trained care coordinators to be community health workers and partnered with academic institutions and the Department of Corrections to get people who have tested positive into treatment. There's the Zero is Possible, or ZIP Coalition, which are local coalitions aiming to end the HIV and Hep C epidemics in Indiana. And they aim to diagnose, treat, prevent, and respond quickly to outbreaks. Next slide, please. There's also a huge focus on provider trainings. So that aims to empower primary care providers in rural and underserved areas to treat their patients without having to send them to an academic medical center. Some of these efforts include our HCV ECHO, or Extension for Community Health Outcomes. It connects primary care providers to teams of medical experts to improve access to high quality Hep B and C treatment. And they meet for 1.5 hours twice a month. And then there's INHAMP, which is the Indiana Hepatitis Academic Mentorship Program, which trains primary care providers. It includes 2 8-hour trainings plus 2 of the 1.5-hour ECHO sessions. And then upon completion, providers can treat Hep C without needing to send this patient to a specialist. Next slide, please. All of these efforts across the state have made a difference. This is updated surveillance data from 2018 to 2022. So what I showed earlier was 2015. As you can see highlighted in the red box there, in 2018, the acute Hep C infection rate was 4 per 100,000, and by 2022, it was down to 2.2 per 100,000. Next slide, please. So I'm going to give a few examples of specific community-based research projects I worked on for Hep C. I have projects working with patient and community advisory boards, provider advisory boards, and community organizations like IU Health Positive Link. Next slide. Specifically, I worked on a community-based intervention development within one of our federally qualified health centers as part of a career development award I received. We targeted baby boomers for this project because at the time they were the age group that was universally recommended for screening. And we pulled data from the FQHC and found that only 15% of eligible patients had actually been screened. And I would actually consider this group of people really low-hanging fruit. They're connected to a provider, they're accessing healthcare, and even they weren't getting screened. So we decided to do an educational intervention to improve awareness of Hep C and screening recommendations, and developed a multi-level intervention and worked with a community advisory board and a provider advisory board to do this. Our community advisory board consisted of 4 members who are demographically representative of the FQHC. Median age was about 65. 3 of the 4 were female, 2 were Black, and 1 was Hispanic. And the provider advisory board consisted of 2 gastroenterologists and 2 primary care providers. 3 of the 4 were female, 1 was Black, and 1 was Hispanic. Next slide. So we developed a multi-level intervention. At the patient level, the intervention included a pre-visit reminder letter of their upcoming clinic visit, which included that they were recommended for Hep C screening, and then an educational flyer was in with the letter. And that included information about what hepatitis C is, what screening is, and why they need to be screened. And then we developed an educational video that they were given in the waiting room during their clinic visit. Their providers received a one-time lunch and learn educational session, followed by monthly performance feedback emails with their screening rates compared to overall rates in their clinics. Next slide. Our community advisory board provided input and feedback on the patient level intervention, and they gave feedback on content, modality, graphics, pace, length, and what information is important to them. And providers gave feedback on similar constructs, content, modality, in-clinic implementation, preferences for contact, important information. The feedback wasn't always specific to content. I'll give you an example of that we can go to the next slide. So this is an example. It was just a stock photo we had as part of the educational video for patients. It was really just meant to fill white space, but we started with the picture on the left, and the advisory board did not like it at all. They expressed doubt that anyone in their age group could or would attempt to jump that high, and they didn't like that the people were not demographically reflective of the patient population. So we ended up changing that picture to the one on the right, which was much more acceptable to them. They said the people in that picture looked happy and seemed to be relatable. Next slide. So we did cognitive debriefing interviews afterwards and found that the intervention was feasible, acceptable, and usable to relevant stakeholders. We did both patients and providers for these interviews. And the citation with the full findings from the cognitive debriefing interviews and intervention development is there if you'd like further information on that. Next slide. So some rules of thumb for successful community academic partnerships include involving the partner really early in the process. I've noticed a lot of times academics have these ideas in mind and develop it and then take it to the community partner, and then the community partner says, there's no way that can work with their clinic flow or with the way with what the population needs. So involving them early is crucial. Having a clear understanding of the project and expectations on both sides. I myself make myself available for activities outside of the research for the community partner. That includes going to health fairs or giving expert talks if they need me to. Having a clear communication plan and following through on responsibilities, and then listening to them as the expert and appreciating their insights. Next slide, please. The community partners and research both bring unique expertise to the team. The community partner really has the deep knowledge of the population and the unique contextual barriers they're facing, as well as the knowledge of the clinic flow and their model of care. And the researcher has the topical expertise and the evaluation and grant writing skills and knowledge of implementation of national efforts and programs. Next slide, please. So building on my community-based work for the in-clinic educational intervention, I've now started a new project that will reach beyond that low-hanging fruit people who are already accessing healthcare, for a new project that will work with harder to reach populations who may not be readily accessing healthcare. So either people experiencing homelessness, people without access to medical care. And this is a collaboration with biomedical engineers at Purdue and our community partner Positive Link. Our biomedical engineering colleague, Dr. Jackie Linus, has a point of care diagnostic test for HIV that can be modified to work for hepatitis C, which would cut out the need for the antibody test and the need to send the RNA PCR test to a lab for results. However, most diagnostic tests are developed without input from the end users. So we're involving our community organizations, patients, and providers in the development process of the point of care test to ensure the end product is one that's feasible, acceptable, and usable to key stakeholders and can be readily implemented in the clinic. Our primary community partner for this is Positive Link, who we've worked with starting with the initial grant writing process. And now I'm going to pass it off to Emily for some more background on the great work they do and her experience with some academic partnerships.
Thanks, Dr. Casting. Hi, yes, my name is Emily Brenniger. I am the manager for prevention services at IU Health Positive Link. Next slide, please. So I'll just briefly go over the kind of who we are, what we do, so I can focus a little bit more on what we have been seeing that's working in getting folks engaged in care around Hep C treatment, as well as some things that we have learned over the years in partnering with researchers. So we are an AIDS service organization is how we started many years ago, back in the early 90s. We began doing HCV testing probably around 2009, 2010. And it is more and more becoming a greater part of the work that we do. And that's not just within our organization, but really with pretty much all of the AIDS service organizations here in Indiana. But we provide HIV, Hep C, and STI testing and treatment. We do linkage to care for HIV and HCV medical care. We also can do linkage for PrEP and PEP for HIV. We have medical, non-medical case management for people with living with HIV. More recently, in the last couple of years, we've begun doing care coordination for people living with Hep C. We also have a small department that does financial and housing case management for people living with HIV. Next slide, please. Lastly, one of our newest additions is our medical clinic. We provide HIV primary care, so not specialized infectious disease care in most situations, but HIV primary care, Hep C treatment, and access to PrEP. Just a little bit more background about who we are. So as I noted, we were founded in the early 90s, 91. Our main office is in Bloomington, Indiana. It's the home of Indiana University. We're kind of in the south central region of the state. But we have offices in areas all around the state, kind of not so much in the central Indianapolis urban area, but really all of the kind of central Indiana areas around there. So IU Health is part of we are the largest health network in Indiana. That said, we function pretty much like a standalone community-based organization. We do get support from the hospital, but our day-to-day looks a lot less like a hospital clinic and more like a community-based organization. We're 90% grant funded. Other kind of things to note, we serve 51 counties in Indiana. They're predominantly rural. Our counties have a population of anywhere from 12,000 to 186,000. So I'm sure for those of you in California, that seems quite small. Most of our funding is federal pass-through grants that come through the Indiana Department of Health, so CDC, HRSA, HUD, SAMHSA. We also have some grants through a fewer smaller and private foundations. Next slide, please. So getting into the populations that we serve, so all funding is directed to reaching those who are at the greatest risk for HIV and hepatitis C. In Indiana, primarily, that is men who have sex with men of all races and ethnicities. For HIV, we have seen the rate of HCV increase in that population as well. Individuals who use injection drugs, really large population there, as well as adolescents. We're seeing risk in adolescents kind of all over the board. So it's no longer, just either, young men who have sex with men. We're seeing all kinds of risk amongst adolescents. And where we reach these populations, we go to where the people are. And I loved hearing Richard and Jordan both noted there was a lot in their presentations about just you have to get to the people. And I absolutely agree. So street encampment outreach, we go to bars, we go to substance use treatment programs, university events, population specific events, and syringe services programs, huge for Hep C. Our partnerships with our SSP friends are really integral in a lot of the work that we're doing around Hep C. Next slide, please. So our approach, I'm actually going to start with that bottom one, harm reduction. And this goes within all of our programming. We really work from a harm reduction approach. So we know that we really need to start where the patient is. We need to start with their priorities, and we need to build their trust in order for us to then be able to provide them the services that we know that they likely need, but they may not have a clue that they need yet. And that includes things like hepatitis C testing, hepatitis C treatment. So we utilize research recognized best practices in the work that we do. Again, that big thing of bringing services to the people rather than expecting them to come to us. By no means is this foolproof, because we don't work in systems that are set up to do that. So it takes a lot of work. It takes a lot of piecing things together to make that happen. And it's something that we strive to continually develop, as well as developing relationships with other community partners, agencies, and stakeholders in the populations we're trying to reach. And we've really found that starting that relationship with asking how we can help. Not telling them how we can help, but looking really to see where their priorities are first and seeing how we can mesh those priorities. Recent programs that have worked and are working, some of these are very, very new. So I want to be upfront about that. Drive-up rapid testing for HIV and Hep C is something that we started during the COVID-19 pandemic. We are in a outpatient medical clinic setting. There was no preventative medicine happening. We couldn't get people in for testing unless it was really almost an emergency. We were like, how are we going to still do our jobs? And we developed a way to do. We do a lot of rapid testing of how to do that on a drive-up basis. Drive around to the side of the building, call the number, do risk reduction, counseling, talk about concerns, needs over the phone. The tester goes out, they do the mouth swab or the finger stick, they go back inside, they let the test run, they call the person back. If they need to go back out, they do. If not, they might be able to do any of that follow-up education and referral over the phone. If there's a reactive test, we absolutely would bring the person inside at that point. But we continue to do that because it was so effective. And I think it's just a really good example of one of those things that we had to be pushed to a point where we had to get really creative before we found a new way to do something, and it stuck, and we still do it. Street and encampment outreach. So that is something we also started doing more of during the pandemic, really knowing that, people who even had the ability to get to us weren't going to get to us. So especially people who had a lot of barriers, a lot of health disparities, including those who are unhoused, were really going to have difficulty getting to us. So worked with some other of our local community partners, including our SSPs, to really build that up. And then with our HCV care coordination, so the Connect to Cure initiative that Monica mentioned, this has been newer in the last really just year and a half is when the big expansion has happened. And I'll talk a little bit more about that in a second. But another thing that is very new within our IU health system is all of our emergency departments around the state are now doing universal HIV and HCV screening. That maybe, I don't know, is something that is done more commonly around the country. It was not done here. So now everyone who does not have a documented HIV or Hep C test on file is offered testing. Next screen, please. So I really wanted to focus on this HCV care coordination piece. So basically what it is medical case management for people living with HCV who want to be treated for Hep C. The Connect to Cure initiative really helped expand that across Indiana. We were able to hire in early 2023 6 new Hep C care coordinators. We had one as part of kind of a couple-year trial project that our State Department of Health was running, and it was going pretty well, but we didn't have the infrastructure around it. We didn't have enough providers to refer to. We didn't have, we were really building that system of care based on HIV care coordination, which honestly, there are a lot of similarities, and that model of care does fit pretty well. There are some, things that are a little bit different with Hep C for sure. One, in theory, hopefully, this is going to be a short-term relationship with the care coordinators. Treatment now is 60 to 90 days. And so our hope is that from the time we get a client, we only have them in our case management services for about 6 months. What those care coordinators really do is help address their barriers to care. That can be a number of things, going back to asking them what they need. First of all, they may not know much about Hep C. They may not know what it does, how it impacts them, why it's important to get treated, how it's transmitted. Alternatively, we find a lot of people who have actually been living with Hep C for a long time. And by a long time, I mean, 5 to 10 years maybe. They had no idea they could get treated because the treatment has changed so much just in the last several years. Or they've had providers tell them, no, you can't get treated. I'm not treating you until, you've had a certain number of years where you haven't been using substances. We know that that is not the recommendation now. Treat people as soon and as early as we can is the way that we really want to go. As far as other barriers, access to telehealth has been one of the biggest successes for us. We've had some clients, our care coordinators have maybe not even met face-to-face in person because we have just figured out how we can get all of this done virtually. We're fortunate. It was not an easy thing to get set up actually, but we're fortunate that we have that availability for folks. And it's been really effective and really helpful, especially again, we work with a lot of folks in really rural areas. So, no public transportation, not just bad public transportation, just non-existent. We have many counties, they don't have Uber. So that transportation component can be really huge. We can also send the care coordinators out to folks. One of the things that I really love about this Connect to Cure program as well, while we're part of a big medical system, we have providers that treat Hep C. If there is a provider closer to the person that is willing to treat HCV, that wants to do it, we'll have our care coordinators work with them regardless of who the provider is. They don't have to necessarily be within our IU Health services network. And it kind of seems like a little thing, but in the grand scheme of, large healthcare and corporate healthcare in these days, sometimes that can be more difficult. So we just want to eliminate as many of those barriers as we can to get people into care. Our care coordination services are currently free of charge. I anticipate they will hopefully always be free of charge to the patient. However, Monica had mentioned that we have been in the process of getting our care coordinators trained to be certified community health workers. Community health workers are actually billable towards Medicaid and insurance now in Indiana. That's a very, very new thing. So that system is still being set up. So we're hopeful that in the long run, that might be something that we'll be able to utilize as well to, offset that cost as this program is grant funded. And, I'm preaching to the choir when I say that changes frequently.
Can you wrap up? We have about a minute left.
Okay, so sorry. Let's see, next slide, please. Let's go ahead to that next slide, the one with the graph. So I won't focus on this. It will be in the slide deck. This just shows a little bit about what we've done. Again, all of this data, this slide is really just between probably May, June of 2023 and March of this year. So really kind of our first year of providing these services. And I think the big one to focus on here is that in that time, we had 99 people start on Hep C treatment. And by March of this year, 39 had completed treatment. I mean, thinking it was a very new program, we've got, it's September, October before we're even seeing people complete treatment at that point. And by March, we had 35 people who had actually completed their SVR12 labs, which is that lab that we do 3 months post-treatment to be sure that they have in fact cleared the infection. Last slide. Okay, so sorry, the partnership with academic partners, and really Monica touched on all of this. The fact that while our goals are typically the same, the method often isn't. So involving community partners as early as possible in your research planning, I think is really, really key, and having those very transparent conversations. I think sometimes community organizations were like, we want to please the researcher. We know we need your help. This research needs to be done because the money follows the research. But coming into that collaboration, just being very transparent with each other of what the goals are, what you hope to outcome, and to be sure that we can meet the needs of what the research is hoping to do, how it's designed, so that it really, works the best for both of us. So thank you so much for having me.
Thank you, Emily. And we have 2 panelists that we have today, so wanted to give some time for them to share their thoughts, and I'll turn it over to Lindsay to introduce them.
Thank you so much, Rena, and thank you to our amazing presenters. It's a really exciting topic. I just want to briefly introduce our 2 expert panelists, Dr. Terry Cohen, who's president of the Hepatitis B Foundation, where she conducts research and implements programs to reduce health disparities and improve health outcomes associated with Hep B, hepatitis delta, and liver cancer. She's also co-chair of the Hep B United Coalition and co-founder and chair of the Hep B United Philadelphia and the Coalition Against Hepatitis for People of African Origin, just to name a few. She's involved everywhere. And then we're also joined by Dr. Adrienne Simmons, who's Director of Programs for the National Viral Hepatitis Roundtable, which is a program of the Hepatitis Education Initiative. And at MVHR, Dr. Simmons works with patients, providers, and public health partners to break down barriers to viral hepatitis care with a focus on historically marginalized communities. So these are really 2 individuals at the forefront of hepatitis elimination in the United States and globally, and have their ear to the ground on what's going on. So I'll hand it over to Dr. Cohen to start.
Thank you so much, Lindsay. This has been incredible for me. I've been furiously jotting notes. I just want to thank our excellent presenters. You've really been able to highlight the importance and the effectiveness of community-led and community-engaged research and programming. It is incredible to see the outcomes that you can have when you leverage and you highlight and you harness the strength and the power of local communities. And I also want to thank our presenters for pointing out the challenges. It's incredible to see what you're able to do with such little resources, and to understand what some of the challenges are that we still face in the future. I want to just spend a few minutes talking about how we can build more national-based strategies to help support the work in local communities that you've heard today. And I can use Hep B United as an example because it's kind of what I know. So Hep B United was created in 2011, and it was created as a way to bring people together, people around the country who were kind of working in silos to address hepatitis B related health disparities. What would happen if we brought those folks together and we helped to build their capacity, conduct technical assistance and training, share resources with each other, create mentorship and partnership? What happens if you support that work locally on the ground and really leverage and strengthen the power of the local community? So we built Hep B United in 2011. We had 12 people when we started. We now have over 45 coalition-based partners in 42 cities, 28 states across the US. It's almost quadrupled, I think, in membership since 2011. And it was created specifically to address hepatitis B related health disparities facing Asian Americans, Native Hawaiians, and Pacific Islanders. It has since expanded to include members of the African diaspora communities in the US, as well as people who use drugs. And it is supported in large part by a cooperative agreement from CDC. So I wanted to just highlight some of the things that we've learned, that we've also heard today from our presenters. The strength here and how we can support local community organizations. Well, the strength here is, number one, building multi-sectoral programs. And you heard that today. Being able to bring together different partners, so community-based organizations, local coalitions, academic institutions, health systems, federal partners, people, strong leaders and strong communities. That really helps to break down the silos. It allows for sharing across and between sectors, which we found to be very, very impactful at the national level with Hep United. Also, I think the second key here is elevating the expertise of local communities with an emphasis on learning and sharing best practices, asking what local communities need. What are the challenges your communities face? What are the best ways that you know that you can make change in your local community? With regards to Hep B programming, for us, it was, how can we help you to get people vaccinated, to get people screened, and to get people into care and address some of the discrimination and stigma? So asking what people need, elevating the expertise of local communities, and then building a multi-platform strategy for building capacity that helps meet the specific needs of each community and also helps bring people together. So things like peer partnerships and peer mentorships programs, things like learning collaboratives where you can have people from different partners come together who might normally not work together, but can share and learn from each other. Next slide, please. And so this slide just shows a little bit about what can happen. So what can happen when we support and build capacity among local communities, even with a small amount of investment. And you can see how impactful this has been. One of the unanticipated benefits of building Hep United is that we were able to create a national voice where we didn't have one before. We now have a national unified voice that can help prioritize hepatitis B at a national level and elevate local community voices to the national forefront. That's been really important for us. But if you look at the programming, look at the outcomes of local community partners around the country, they're reaching over 25,000 high-risk people a year. More importantly, for sustainability, they're testing and disseminating innovative strategies to reach communities all around the US and then sharing that with each other. So you can see just how strong and impactful supporting local communities can be. And I just want to point out here that while we focus on hepatitis B and C today, and of course liver cancer that's associated with it, supporting communities like this, building capacity in communities is both sustainable and transferable. It doesn't have to stay with hepatitis B. For example, when we were thinking about building a national tuberculosis coalition, we used Hep United as a template for the creation and the design of TEA. So obviously long-term investment in communities is beneficial not only for individual diseases, but for communities as well. And with that, I'm happy to hand it over to Adrienne. Thank you.
Awesome. Thanks so much, Sherry. I wanted to say thank you to the organizers for having me. I'll just briefly introduce NVHR. I'm going to go quickly so that we have time for questions. So apologies if I'm talking quickly. National Viral Hepatitis Roundtable is the largest network of people directly impacted by viral hepatitis, healthcare providers, as well as public health partners, working together to break down barriers to viral hepatitis care and ultimately advance elimination in the United States. Much of our work is done through sharing best practices, through advocacy, as well as policy change. And so I think our presenters did a fantastic job illustrating why community partnerships are important and the impact that they can have. So I'd like to close out by just summarizing some of the best practices that we've heard, as well as offering some thoughts about how community partnerships might continue to evolve. And so starting with the best practices, you've heard this across multiple presentations, right? The importance of early involvement, of engaging community partners as early as possible in the project development process. And that includes, in grant writing, as well as in all of the various project and research planning stages. Clear communication is critically important, right? Establishing a really clear project management plan that outlines everyone's roles and responsibilities, as well as the timelines associated with the project. Transparency is critically important for building trust and ensuring mutual understanding. So third best practice is really trying to design a partnership that is mutually beneficial to both parties. So making sure first and foremost that the project ultimately meets the needs of the communities that you intend to serve, but also making sure to design the research process in a way that the community partner is able to engage in a low barrier way with the research. We have lots of data and research processes that can be new or unfamiliar to our community partners. And so ensuring that they feel supported in that project is really important. And then finally, we've heard, without the words being used, capacity building, whether that's through funding, through training, through just providing community partners with the resources and support to really implement sustainable models of care that can be scaled up and maintained beyond the initial project funding. Next slide, please. And so, as I think about where community partnerships can go from here, I think it would be remiss to not mention that, community partnerships are only as effective as our systems allow them to be. And so if there are structural barriers that exist, we're going to be limiting the impact of these community partnerships. And so we're seeing various barriers decrease in the viral hepatitis space, right? We've heard mentioned that we now have universal hepatitis B screening and vaccination guidelines. We've been able to significantly improve access to hepatitis C treatment by removing things like prior authorization processes. And then we will very soon have our first point of care hepatitis C test, and hopefully a hepatitis B point of care test will come down the road. So as these barriers are addressed, the window of opportunity for community partnerships really widens. And so we can, in fact, eliminate hepatitis B and C if we design our systems to meet the needs of the most marginalized communities. That's going to take centering the voices and expertise of those directly impacted, continuing to streamline our data processes and eliminating administrative red tape wherever possible, and ultimately just being willing to provide healthcare differently. All of us, as I believe Emily mentioned, have the same goal, and the devil is in the details, and often where we differ is how do we get there? And so really prioritizing developing these partnerships in a way that, again, both the community partner can provide the services that they need, but in a way that doesn't burden them with administrative red tape is really important. So I'm going to pause there and turn it over to Lindsay. I think we've got a couple of questions that we'd like to address in our last few minutes. Thanks so much for having me.
Thank you so much, Adrienne and Cherry, for those wonderful remarks and reflections. I think we're almost at time, so we want to thank everyone for joining us today. We will stay on for a few extra minutes for anyone that's available to respond to the questions. And I'll hand it over to Rena for the first question.
Hi, everybody. So I think this was a great presentation, and we saw great examples of how community organizations play a critical role. So I just want to open it up for all the speakers to provide any thoughts that you have for sharing any of your lessons learned and anything that we need to do. I mean, we have a lot to do to reduce health disparities and achieve health equity, but any last minute thoughts that you have that you would like to share? I know there was a question on efforts for hepatitis B vaccination. If somebody wants to take that question, feel free to address that.
Yeah, sure. I can talk a little bit about what we do, and unfortunately, it's not a great answer. We, as a tiny nonprofit, we can't afford to provide the vaccination, although now there are lots of FQHCs that may provide the vaccination either via signing up for Medicaid or Medi-Cal, or through some additional like charity programs. We know vaccination rates are low in the United States, even though it's also recommended. And so if there's more specific questions, I'm happy to go out and do the research as well and try to find the answer. But That's all we can say for our work.
Yeah, I was just going to say that it's actually, having done this work for 20 plus years, the fact that we actually are recommending adult vaccination is huge. And it really reflects all the power of the community engaged work that everybody, and Shari and others, have done to get that. Because we always had trouble, getting people to pay for it. And then, people get into these arguments about why should adults get vaccinated instead of, it's a preventable disease. It's a vaccine preventable disease. Why are we having this debate? And so I think, certainly from the clinical side of things, we actually have to do a better job of quality improvement, and making sure that the various quality improvement measures are measuring this and doing the right appropriate things there.
Yeah, any other thoughts from the panelists or Emily or Monica in terms of what are some of the issues that maybe NIH can consider supporting or funding more research on for all the panelists? No thoughts? That's amazing.
If I may, I just may briefly share. I know the CBO just completed analysis of different legislation related to the national HCV elimination plan. And I think that there's really an opportunity to look at evaluating outreach. I know that's a huge challenge. We're talking about the how effective and important it is to center the voices of people with lived experience, community health workers, and other additional outreach strategists. And I think it's really important that we try to dig into this research, look for not only best practices, but try to find the evidence that bears out from that research in order to inform scale up of those strategies to improve HCV and HBV prevention, linkage, and care.
I would say actually that we sometimes silo too much, and it's HBV here and HCV there. There are issues that matter to people's liver and their lives in general. And we have to start thinking, across things, including fatty liver, because actually, if you thought about a thing that affects people's liver, that's actually the most prevalent thing right now. And of course, co-disease with Hep B or Hep C makes things a lot worse. And so I think we need more research on sort of comprehensively addressing people's liver health. I actually think that I don't just want them to get Hep B testing. I want them to get Hep B testing and Hep C testing and Hep B vaccination, and lose weight and stop drinking alcohol. I mean, it's like people are people.
Yeah, to what you mentioned is really important, and we have been supporting some research where even for screening purposes, can we screen for multiple diseases at one time? There are lots of these home available kits for hepatitis, for HIV, for HPV, for so many other things. Can we do something, combine them so that people who are at high risk can get those testing available at home or in some mobile clinic?
Yeah, that would be, if you're asking about, what would be an interesting area for NIH to fund research, that would be an incredible project or program to look at, because for hepatitis B right now, we don't even have an FDA approved point of care test, so it makes it very challenging. But how do communities and providers feel about those kinds of sort of multi-level point of care or multi-platform point of care tests, and how do you improve awareness and acceptability of that? I think both from the provider perspective and the community perspective, but also I think we need more research into point of care testing for hepatitis B for sure.
Yeah, and also what Emily mentioned in terms of having access to care and treatment, what is covered. I mean, having free treatment available is great, but it's probably not sustainable. So how do we take care of that? And how does policy impact, like what Monica mentioned, like if you have coverage, and then how that shows a great increase in uptake. So those are also probably some areas that more research can help.
Dr. Duff, I just wanted to follow up on that and say that you can design the best community partnership. We can design a really robust hepatitis C screening and treatment program, but if your state Medicaid program still requires a prior authorization, which takes many days, if not weeks, ultimately we're not going to be seeing the impact of that program that we want to see, right? Because we're going to lose people in the process. The same example can be applied to the absence of a point of care test for both hepatitis B and hepatitis C. And so I just would like to challenge folks to think about, beyond the, reflecting on how we can each be good collaborators in a partnership, whether you're on the researcher side or the community partners side, to also be thinking about the big picture structural policy changes that need to happen to actually see these partnerships reach their fullest potential.
Thank you. And before we close, I just wanted to remind you that NIMHD is interested in research proposals from all of you who are working in this field to apply to this funding opportunity that we have created for reducing and eliminating hepatitis disparities and liver disease and liver cancer. So it's PAR 24-207. Lindsay is sharing that slide. So this is again to encourage people to submit applications, community-based research on policy level, multi-level intervention ideas that you have. Please reach out to us for any details that you may want to learn about this. So with that, I think I'd like to thank the NIMHD Planning Committee, especially Dr. Olga Haran, for helping in planning this and working with all of you. And I'd like to thank Lindsay and her team for doing all the logistic work for making this event possible. Lindsay, back to you.
Yes, just to thank everyone again and to apologize for going over time. There's just so much great content here to talk about, but discussion doesn't have to stop. As mentioned at the beginning, the recording, each of the speaker talks, including our panelists, and the slides will be available on the Coalition's website, and we'll also prepare a report with just many of the lessons learned and recommendations coming out of today's discussion. So please be on the lookout for that. And I'll just close by mentioning there's 2 upcoming webinars in this series with other institutes at NIH. If you're interested in joining, we'd love to have everyone involved here today come back. And we hope you have a great rest of your Thursday and continuation of celebration of Juneteenth. So thank you.